So usually we answer this question, how? No, or very rarely. The question is why? So the first answer, I'll have two reasons that I think are important. The first one is that most of our therapies have narrow therapeutic window. In other words, therapeutic effect and the dose response for that therapeutic effect is simply too close to the toxic effect dose response curve. Essentially, being an oncologist is all about optimizing this therapeutic window. If this was really wide, then general practitioners handle the patient. But it's precisely because it's narrow that we have to be very careful. But this is first reason. And a lot of what I'm going to be talking about today is about this. It's about shifting the therapeutic effect curve to the left and the toxic effect curve to the right. In other words, we're trying to identify unique drivers of the biology of ER-positive breast cancer that allow us to do this, and also select patients carefully to minimize any, and then manage them carefully to minimize any toxic effects. But there's a second reason, the answer that we gave about our ability to cure metastatic breast cancer. This is one of the scariest slides that I've ever seen. Every student of oncology should be very, very familiar with this. What does this slide show? It shows that by the time we diagnose cancer, we are already 3/4 of the way along the trajectory of that disease. Essentially, to be able to either palpate or clearly see something on the scan, we need approximately 10 to the 9 cells. From that point, 10 to the 9, to death of the patient, we have only 3 logs. Just 3 logs. 9 logs already happened. And during that time, the tumor managed to become extremely clonally heterogeneous usually, and it's seeding distant sites often and establishing first micrometastatic or even macrometastatic lesions. So as you see, once we are in the clinical range, in these 3 logs that I shaded here with gray, a few errors can quickly get us in trouble. And even successful therapies, as you can see, need huge amount of cycles to actually get us to 0. Sometimes what we hope actually just to get to this range between 0 and 10 to the 5 cells, which is where immunotherapy can potentially have the greatest benefit. So you're trying to debulk the disease so much that maybe immunotherapy or immune mechanisms can kind of finish the job. So please, if there is one slide to memorize from this whole discussion, it's this one, because we often get fooled even by really dramatic responses, either very deep partial responses or complete ones, where we just don't see the disease. But actually, that's just the tip of the iceberg. And we're still dealing with a huge amount of cells that ultimately can completely reconstitute the tumor. So to continue, we now have the definition of the problem. Treatments have very narrow therapeutic index. Here I'm showing you a very commonly used drug in metastatic breast cancer, capecitabine. Look what we can get. We can get only about 7-8 months PFS with maybe 25-30% response rate. Because if we try to do more, if we try to either increase the dose or give it continuously, we run into severe GI or skin toxicity. So then the hope is to try to find these drivers of the behavior of tumor cells so that we can exploit them, target them in a more precise way, and then shift that tumor response curve to the left. And one of the most sort of beautiful aspects of translational research in the past 10 to 20 years is how far we came in mapping out the signaling networks that drive the behavior of these tumors. So one of the sort of fundamental discoveries is that estrogen receptor, you see it top left corner, directly controls cyclin D. And that cyclin D, together with CDK4/6, as you can see on the right, controls the phosphorylation state of the RB, and that's ultimately what controls the progression in the cell cycle. So think of ER and CDK4/6 as sort of two aspects of essentially same biology. Not just that, additional signaling nodes within this network are tightly linked to both of these components, so that when you inhibit ER or CDK4/6 or both, you have compensatory activation of additional signaling modules, particularly PI3 kinase, AKT, and mTOR. So almost conceptually, you can think of this whole network as a simplified triangle. And pretty much anything you do to one component of that triangle will result in some sort of reaction or effect at the other part of this triangle. And a lot of drug development is trying to do several things, either optimize or improve inhibition of a particular node, novel ER agent, novel CDK inhibitors, novel PAM pathway inhibitors, develop their combinations, either doublet or triplet, or even higher order combinations. And my slides will cover some aspects of that. Well, first step was actually not ER CDK4/6 doublet. The very first sort of targeted therapy, believe it or not, in ER-positive breast cancer was introduction of mTOR. As you know, Jose Baselga, fellow I learned quite a bit from, was the first to introduce, finally, after decades of simply studying ER, introduce essentially the first targeted therapy doublet, where he combined exemestane and everolimus with a significant clinical effect, as shown on this slide. This was recapitulated with combinations of everolimus with fulvestrant, and in clinical practice, although not maybe as often, we still utilize this combination in select patients. The problem, though, is despite the fact that you're hitting PI3 kinase pathway, additional research has shown that whether that pathway is activated through PI3 kinase mutations or not has no bearing on the effect of everolimus, which was somewhat puzzling. How is this possible? So one explanation is that you're simply too far and too downstream in the signaling sequence that drives the PI3 kinase pathway behavior, or you're not sufficiently inhibiting that node. And in the setting of highly activated pathway through these mutations, you're simply not seeing that difference. Obviously, there's a lot more that we could discuss here, but after this initial success, we tried to desperately leverage the presence of oncogenic mutations as a sort of treatment selection strategy, and that's why we worked quite hard on developing various PIK3CA-directed therapies, including PI3 kinase alpha inhibitors, and the newest generation of those so-called PI3 kinase mutant selective. But let's go back now to the second sort of success and now the dominant strategy for the treatment of this disease, which is to go after the base of the triangle, to go after ER and CDK4/6. This just summarizes how important that strategy is. This is one of the most impressive bodies of research that you see in all of oncology. I cannot really find as many good examples of this extensive series of global phase 3 trials that demonstrate the utility of CDK4/6 inhibition. As you know, the first of those was Paloma 2. Then you have Mona Lisa 2, 3, and 7. You have 2 Monarch trials. What these have shown that you can control the disease in a way that's essentially unprecedented. When I was a fellow, we would quote overall survival of metastatic breast cancer somewhere at the order of 3, maybe 4 years. And now, as you can see in MONALEESA-3 for Western ribociclib in the frontline setting, just that one therapy gives you 34, almost 34 months. Where things get a little tricky and where the differences between these agents really come into right in front of us is the fact that not all of these agents produce long-term effects, specifically prolongation of OS, and we'll talk about why. One of the most compelling studies that I know is this study by Aleix Prat, who looked at pooled data from MONALEESA trials, looking how different subtypes of ER-positive breast cancer with different levels of aggressiveness respond to combined ER and CDK4/6 inhibition. And what is surprising is not that you see, for example, really kind of wide separation of curves in, for example, luminal B tumors in this B panel, but that in seemingly indolent tumors, the luminal A, you also see clear separation of the curves with hazard ratio of 0.633 for PFS. So that just tells you that ER and CDK4/6, that base of the triangle, is critically important regardless of seeming aggressiveness of these tumors. There's actually no good way to sort of guess, this tumor is so slow growing, therefore maybe we can just treat it with monotherapy. No, actually across all subtypes, the ER and CDK4/6 are almost like two legs that the cancer stands on. I sometimes even get a little bit irritated that how come after all these years of research on CDK4/6 inhibitors, we don't have a predictive biomarker for them. We do. Predictive biomarker is what? Estrogen receptor. All right? And I showed you the signaling machinery that actually is behind that. So the reason we are not actually finding other clear winners in this search for predictive biomarkers because the biology is quite complicated and you have actually many of them, and we'll talk about it quite a bit. This just summarizes now OS data that we see. It's not that common to see such a wide separation in a disease such as ER-positive breast cancer, but here you have ribociclib achieving statistically significant OS benefit in MONALEESA-2 that actually the improvement is 12.5 months, an entire year. That's quite a bit of time. That's enough time for a small child to start walking, for a junior in college to graduate. So, giving this much time to a patient with metastatic breast cancer is simply a reflection of that deep understanding of biology of these tumors. We have somewhat similar, although not statistically significant effect that we saw in Monarch 3, but in the final OS analysis, the combination with abemaciclib and AI did not really meet that pre-specified boundary. And to this date, still, it's just ribociclib that has a clear OS benefit in frontline setting. But those studies, despite their impressiveness, to me, are not as revolutionary as this one. So Right Choice is really an intriguing study to me. Why? Because they tested a very straightforward strategy. They said, hey, on one hand, let's use brute force. Let's hit the tumor with 2 chemotherapies, not 1, but 2. Docetaxel, capecitabine, paclitaxel, gemcitabine, capecitabine with vinorelbine. So chemotherapy doublets in young patients. These are very menopausal women who have somewhat higher threshold for ER expression. We need to have at least 10% or more. It's a de novo disease, mostly with no prior systemic therapy. And these patients had very aggressive disease, symptomatic visceral metastasis, rapid disease progression, or impending visceral compromise, markedly symptomatic non-visceral disease. So this was, the deck was stacked against a seemingly more, maybe not as aggressive approach as you would think, looking at combination of letrozole or anastrozole with ovarian suppression plus ribociclib. All right? So here we are literally testing whether being smart is better than simply hitting this tumor hard with doublet chemotherapy. And what did we see? We saw a hazard ratio of 0.54. Now, this study, and this is classic for academic discussions, got a bit of a trouble because our understanding of visceral crisis was evolving. We are usually pushing for endocrine plus targeted therapy combinations up to the point of so-called visceral crisis, which is essentially imminent failure of vital organ, not just mere presence of significant amount of disease in the liver or lungs. So as the definition was evolving, some of these patients became somewhat kind of, do they really belong in this subgroup of patient with visceral crisis or not? And then we kind of lost the plot, where the main point actually is biology versus brute force. And this is what this study should really tell us here. Using just endocrine therapy plus targeted therapy, but you're hitting the tumor where it hurts versus hitting with a DNA damaging plus microtubule poison and trying to see how that pans out. And we know how it did. Now, the problem with all of these approaches is that sooner or later tumors become resistant. And this summarizes some of the key observations that we have in post-CDK4/6 context. The most important driver resistant to CDK4/6 inhibitors, clearly and unequivocally, if you have a biallelic loss of RB, remember, that's what CDK4/6 and cyclin D control. So if you have a loss of that RB, this is where you have clear resistance to CDK4/6 inhibitors, at least when given as a doublet. But then you have a whole slew of additional drivers which can modulate the responsiveness even just slightly or more significantly. That includes PI3 kinase pathway, AKT alterations or AKT activation through PTEN loss, and then somewhat surprisingly, probably the most common acquired alteration in the context of dual blockade with ER and CDK4/6 is ESR1. When I initially thought about this, I was like, why? Why is this? Why? How is it possible the tumor is becoming resistant to dual blockade simply by altering ER? But if you can visualize me standing on my two legs, if you just knock one of my legs, I'm standing. If you knock the other one, I'm still standing. Right? You really need to knock both of them. So if the tumor becomes essentially ligand independent, estrogen independent through activation of ER, through these ESR1 mutations, you're essentially reestablishing one of the pillars that the tumor stands on. So then it actually is not surprising that the doublet starts failing. And we now have extensive research how we can actually manipulate this, how we can act on it early on and prevent the emergence of full-blown resistance. And I'll talk about this later in the slide. One aspect of this biology of tumors in the post-CDK4/6 setting that's somewhat scary is that tumor may completely become independent of ER. And ER loss was probably the first drug sort of acquired resistant mechanism that was described in the context of metastatic breast cancer, but then more recently was actually shown to be a relatively frequent observation with early recurrences on adjuvant CDK4/6 inhibitors. As you can see, the tumor will fight back and try to reestablish ER axis. If it's not able to do that, it will completely become independent of it. So you almost have like a two dichotomous kind of strategies, which require completely different treatment strategies. So as you can see, and I love to quote Leo Tolstoy here, one of the books that, as a high school student, I had to read from cover to cover, and the quote goes like something like this. It says, "Happy families are all alike. Every unhappy family is unhappy in its own way." And this kind of tells you a bit about the heterogeneity of acquired resistance in post-CDK setting. Every resistant tumor seemingly is resistant in its own way. There are some patterns, there are some convergent phenotypes that we can exploit, but the sheer volume of these alterations can sometimes be daunting. So what are some of those patterns that we can therapeutically exploit? Well, one of those is reactivation of this top component of the PI3 kinase, and obviously a pathway. And obviously, if you know anything about my research for the past 10, 15 years, we have sequentially tried to improve our options as far as targeting of various nodes in these pathways are concerned. The very first approach was based on simply trying to understand how PI3 kinase mutation function. And if you could kind of make yourself small, PI3 kinase looks almost like a kidney-shaped structure that has this regulatory domain unit, a P85, attached to it. And then there are these kind of components that kind of grab the catalytic subunit, almost like brakes on the car. And when you have a mutations, those interactions cannot happen. It's almost like you're pushing the brakes on the car and there's nothing to actually catch the discs. These domains that you see here, NSH2 is one of them. Essentially, you cannot establish the contact, and now the car is speeding down the highway. And this is what happens with PI3 kinase mutations. The usual regulation of the protein is disrupted, and now the protein is hyperactive. The very first agent that actually made it to the clinic was this one, BYL719, where for the first time we were able to actually selectively block the protein that was mutated in tumors. In the beginning, we were so greedy. We wanted to hit all of these proteins, hit them continuously, alpha, beta, gamma, delta, and mTOR, and then do that continuously without any breaks. And those strategies failed only when we realized that we had to make a choice and hit the PI3 kinase alpha, which is encoded by PIK3CA, we're able to see a good result. And to my chagrin, when the first trial completed, where we tried to give this agent to PIK3CA mutant tumors, we got this kind of waterfall plot, where we had a few responders, a few rapid progressors, and then in the middle, we had all of these patients with just stable diseases or slight progression, but it seemed like the tumors were just kind of standing there. And I was like, okay, this is it. My career is over. I have this best possible drug that's hitting the very target that's in the tumors, and this is what I get. And I look at my boss, and he's developing the brafenib, trametinib combinations, the BRAF combinations in melanoma, where you're seeing waterfall plot that's completely skewed to the right. And I was like, what is going on? Like, why bona fide oncogene hit by a proper drug is giving us this result? And what happened is something that I like to call a Sherlock Holmes principle, which is we started studying these tumors and we were so focused on what's present in them. And then we realized, what's not present? And if you have ever read or watched Sherlock Holmes movies, there's a famous story about the dog that didn't bark. Essentially, Sherlock figured out that intruder, a thief or a killer, was actually known to the victim because the dog didn't bark, did not recognize the person, and did not bark. So sometimes looking at what's absent in the tumors actually is the biggest clue to our understanding of the biology of disease. And what we realized that in our clinical trial, we had a sort of basket approach where we're putting any PIK3CA mutant tumors, and those that had concomitant RAS mutations, the colon cancer patients, universally did not respond to the therapy, and where you did not have that collateral activated protein, this is where we were seeing responses. Where was that? It was in breast. So simply selecting for something is not enough. You also have to select against. So this is a fundamental principle of precision oncology. We're so focused on, hey, this patient has PIK3CA mutation, therefore let's give them the drug for it. But you have to look at other things. What is actually also there and not there? And this will actually tell you whether the strategy is going to work. So then the first step was to simply fine-tune the patient population, focus just on ER-positive breast cancer with simple genomic profiles, with simply just PIK3CA mutation, but still that was not enough. What then we had to do in parallel as doing the clinical trial was a series of studies on cells in the lab, where we actually realized when we give PI3 kinase alpha inhibitors to PIK3CA mutant ER-positive breast cancer, you have this rapid adaptation to the inhibition, where estrogen receptor and its transcriptional activity dramatically increases. That was the first proof of this two-leg principle that I told you. Essentially, the tumor is shifting from one side to another as you inhibit one angle or the other. And the only way to even achieve temporary effect is to hit both. And now the waterfall plot, when you do that, when you combine fulvestrant and alpelisib, the waterfall plot starts looking a little more appealing. But often when we talk about drug development, we look backwards and we give seminars and we tell stories. I'm taking you guys to kind of that time where we have a promising agent, we have a selection strategies, we are trying to figure out what's going on. And until we figure out that we have to look at what's present and what's absent and account for these adaptive interactions, we actually couldn't come up with a strategy that's going anywhere. And based on this, Solar One was started, which was a positive trial. But I see this trial as a sort of proof of concept approach because we still had too narrow therapeutic index to more widely use this. But certainly it established that PIK3CA mutation can be used as a predictive biomarker and that its targeted with selective inhibitors can produce a clinical effect. Subsequently, additional strategies were developed, specifically the AKT inhibition with capivasertib, which gives you, hazard ratio about 0.5 with 7.3 months versus 3.1 month. But there, you're kind of moving a step away from that activated protein. And the question is, is this the best approach? And in all of this, what I was trying to show you, and we cannot ever forget, that almost as a physical principle, we always have to anticipate that for every action that we do, there is an equal but opposite reaction. The tumor is literally constantly shifting, and we have to find better ways to anticipate this and prevent those reactions. So at the same time, we are giving these novel agents to patients, watching and profiling their tumors pre and post, monitoring their ctDNA profiles, specifically variant allele frequencies of the oncogene itself and other concomitant alterations. We established one of the largest rapid autopsy programs in the country, where within approximately 6 hours after patient death, after we lost the battle, we actually say, hey, our research does not end here. And what we can do is we can map out all the lesions within a patient and see how tumors change, how those lesions change from one site of disease to another. What shocked us is that in a single tumor, to acquire a adaptive sort of a change, a PTEN loss that clearly drives resistance to PI3 kinase alpha inhibitor. Why? Because you have activation of PI3 kinase beta. You can actually do that 6 different ways. Essentially, every lesion is ecosystem of its own, fighting the drug and independently developing resistance alterations. It's almost like wings on bats and wings on birds. They essentially develop multiple times. Why? Because wings are useful for flying. Here, the tumor is independently developing resistant alterations through completely distinct mechanisms, but they converge on the same phenotype. This is actually one of the first examples of convergent evolution in the context of drug resistance, and ended up being published in a obviously distinguished paper. But the reason I'm the reason I'm showing you this is that this is single patient. Sometimes we think that in the era of big data, AI, machine learning, we need massive data sets. No, we just need to be also clinicians, observe a single patient, understand why they respond, why they don't respond, why they fail responding. And sometimes from that single patient, you can actually almost like a whole portal opens in fundamental discoveries of this disease. And a scary part is, and additional research has shown that something else happens. This PTEN loss can drive resistance to PI3 kinase alpha inhibitors, but then in this paper, we've shown that also drives resistance to CDK4/6 inhibitors. Through the connections that I'm not going to belabor here, what's actually happening is when you have PTEN loss, AKT gets activated, and then an important regulator of cell cycle machinery, P27, gets sequestered in the cytoplasm, and that results in CDK2 activation. Remember, you're using CDK4/6 inhibitor. Now this alteration drives CDK2. So again, the tumor is shifting from 4/6 to 2. And why is this really important? Because now I'm showing you for the first time a resistant driver that causes resistance to two distinct treatments. We call that how? Cross-resistance. All right, so this is one of the fundamental problems in oncology. Not just that you have resistance mechanisms, you have cross-resistance mechanisms, where a single therapy produces a resistant phenotype, where now you're not just resistant to that therapy, you're resistant to more and completely unrelated treatments. All right, so then we have to be smart when we deploy various treatments. And we can't just rely on saving the therapies for later. So a lot of times I hear this, maybe we should be careful how we sequence these therapies. Let's just save this therapy for later. But if the tumor develops a cross-resistance driver, what you were hoping to use later is no longer an option. All right? So this is sort of a cautionary tale that a lot of our treatments are not orthogonal. They're not completely unrelated to each other. And the tumor, through cross-resistance, can actually become resistant to what you were hoping to use at a later point in time. All right? So that's why precision oncology approach is not just about giving the right treatment to the right patient. Often people forget at the right time. All right? So timing is everything. I tell this to my kids, it's like Woody Allen principle. Half of everything in life is just show up. So you have to kind of pay attention to timing. Well, we have optimal time points in the treatment trajectory where we have to deploy particular therapy. And we cannot think of them as an independent treatments that we can easily shuffle and give first line, second line, third line, like they're not independent. And I already showed you one plot and I told you it's scary. This one is scary as well. I don't have enough time. I could talk 15 minutes about this. But what this simulation shows, and it's based on some extensive studies of the actual sizes of lesions, and then utilizing mathematical approaches to actually model likelihood of eradicating lesion based on its size. And look at the leftmost curve, is this gray dotted curve, which is a tumor that you're treating with monotherapy, let's say just tamoxifen or an AI. And out of thousands of genes that are present in that tumor, 50 of them, which is a conservative estimate, can drive resistance to that monotherapy. You can see that the curve drops off. You essentially fall off the cliff around 1 millimeter. After about 1 millimeter, your chances of cure dramatically go down. All right? So now you're like, wow, I know how to deal with this. Dr. Juric is telling me about these two legs, and I'm just going to give combination. And that's the red curve. The red curve, you're not changing anything. Still, only 50 genes can drive resistance to one drug, 50 to another. You're golden. You give that doublet, and look, all of a sudden you can cure tumors that are 2-3 centimeter. You now know that that's not the reality. Why is it not the reality? Because look what happens with the blue curve. A single gene, N12 equals 1, a single gene that causes cross resistance to both drugs shifts your curve back by multiple logs. Essentially, you are now able to cure only 2-3 millimeter or eradicate only 2-3-4 max 5 millimeter tumors. All right? So one of the curses of oncologists is that we think about processes as linear. All right? That's why in late line patients, we get caught because the growth is actually exponential and we can lose a patient within weeks. But we are like, how come, Dr. Juric? My disease was kind of nicely behaved. Yeah, but now there's much higher burden and you're actually growing exponentially. We also think that our interventions are on a linear trajectory. If we don't do something, yeah, we may lose a little bit of activity, but no, you actually fall off the cliff. All right? If you miss a window, it goes down. Your chances of cure or eradication essentially goes down to 0 very quickly. Yet another reminder, the timing is everything. We can't let replicators replicate. We need to hit them early on. So why? Because they just find a way to do this. It's like this little flower just growing out of the rock. It's shocking to me how live cells, they just stay alive. And we have to be really clever and use our approaches at the right time to achieve a good result. Can we use brute force? So now there are these ADCs, sacituzumab, trastuzumab deruxtecan, DXD. We must be able to kill these tumors by concentrated chemo 200 times inside the cancer cell. This is a paper we published about how tumors become resistant to ADCs. And look what's happening. Some lesions develop resistance to the drug by becoming resistant to the payload, essentially acquiring mutations in topoisomerase. Other lesions, completely different lesions in the same patient, become resistant to ADC by altering the anchor, truncating or reducing the amount of anchor at the surface. So essentially, even with a seemingly very powerful therapy, the tumor to these evolutionary processes can actually acquire not one, but two, and in completely distinct parts of the tumor, drivers of resistance. So we must be smarter. And one way to be smarter is to hit the tumor on multiple nodes. And in our 120 is one of the studies that I was involved, where you're now hitting all 3 nodes. You're hitting PI3 kinase with inavolisib, you're hitting ER with fulvestrant, and CDK4/6 with palbociclib, and this is the hazard ratio you get for PFS, which is quite interesting, 0.42, but not just that, you have a 0.67 hazard ratio for OS, and this is in frontline setting in endocrine-resistant patients. But we kind of have to keep going. As you have seen, the theme of my stories, we're kind of constantly trying to understand, can we get a better drug? Is this drug doing a better molecular job than what we have? Does it have a better clinical effect? What accounts for that variability? And then you keep iteratively fine-tuning your approach, and you need better and better agents that hit those components of the triangle. You need to combine them in better ways. So now we have multiple ER agents that they're at our disposal for these combinations. Elacestrant, these are the data for it. Imlunestrant, you know the data. Vepdegestrant, which is a PROTAC, a completely new mechanism of kind of degradation using a relatively large molecule. And then finally, one of the most impressive trials to me is this one, the SERENA-6. Maybe in the audience, there are some who absolutely love this study, and there are some who absolutely hate it. To me, this study actually fulfills all the criteria that evolutionary biologists wants to see, which is not let replicators replicate. If you're seeing emergence of resistance clone, i.e. emergence of ESR1 mutation, and I already showed you this is the main driver of resistance, the tumor is essentially shifting to the left leg, and you say, I don't care, let's just wait for radiographic progression. Actually, SERENA-6 said, no, we're not going to wait. We're going to change the ER backbone to camizestrant, and this is what this strategy has resulted in. It actually works. Now, as a statistician, you can kind of go after this study all sorts of ways. But if you actually look at the entire biology that informs this strategy, I find that this is going to be the right strategy. We're going to have more and more of this. We now have better and better agents that target PI3 kinase. We have heard about gedatolisib at just this year's ASCO, where this multinodal inhibition approach, you're essentially with an IV agent hitting PI3 kinase mTOR, and then you're hitting ER and CDK4/6. So now you're hitting the triangle and multiple nodes, produces pretty impressive results with median PFS 11 months versus 5.6 months at hazard ratio 0.5. Unfortunately, you're relying on an IV agent, and we need better approaches to do this, and also to minimize any chances of hyperglycemia that comes from inhibition of PI3 kinase, where you're essentially going after downstream signaling of insulin. So to enable continuous inhibition, to have an oral agent to do that and avoid hyperglycemia, we now have a series of so-called mutant-selective agents, such as STX478, and this one, zovegalisib, RLY2608. And what they do, they found a specific pocket on this protein that is away from orthosteric sites where existing drugs bind. And through that pocket, they're able to hit just the mutant version of the protein. It's almost perfect therapeutic index, where you're actually shifting those two curves really away from each other because you're not causing hyperglycemia, you're really hitting the tumor where it hurts. And not just that, since you're going after a completely different pocket, we know that these drugs can overcome resistance to existing PI3 kinase alpha agents, which actually you can develop mutations within a pocket of, for example, inavolisib or alpelisib, where the mutation alters the ability of the drug to bind, but these novel agents don't even use that pocket. They're actually away from it, and you can actually prevent emergence of resistance through these on-target mechanism by using an alternative approach such as this one with these PI3 kinase alpha agents. And then finally, we are not stopping with CDK4 and 6 inhibitors. We are desperately trying to optimize the ratio between CDK4 and 6 inhibition. We now have a termocyclib that boosts that CDK4 inhibition, and we have novel CDK4, CDK2 agents where you're essentially trying to prevent these dynamic shifts between 4 and 2, and one of those agents is this drug, RGT419. And then finally, we realize that another way to go after cell cycle machinery is to go after master regulators of multiple proteins in that machinery. And this is where these KAT6 inhibitors come, because they actually control a series of proteins involved in this machinery: estrogen signaling, cell cycle regulation, mixed signaling. And with these agents, we're actually able to produce quite deep responses post-CDK4/6 setting without picking individual nodes. We're essentially going after a master regulator. So this brings our story to a close. We have different ways to sequence these agents, but the essence of what I was trying to tell you, you can't fly a plane blind. You need biopsies. Sometimes you need autopsies to inform the treatment of next group of patients. And you need serial monitoring, ctDNA, to find drivers of acquired resistance, or in the case of SERENA-6, this kind of one of these strategies where you're actually changing the backbone before the tumor becomes overtly resistance. And I believe with this approach, our future is even brighter, and hopefully we'll have even better outcomes as these higher order combinations come. So with that, I want to thank you. There's another evaluation.
I'm sorry, we haven't met. Welcome. My name's Lena.
Oh, okay.
Oh, thank you so much. That was an excellent presentation. It's just incredible. Your base going all the way to clinical work, all the way to clinical trials. Congratulations for that. I think what we'll do now, if everybody
Guys already a celebrity around.
I'm just going to check to see if there are any questions online here. And also we'll open up for questions live as well.
And then I was in a meeting during actually.
So we do have a question actually from Dr. Carmona, who's one of the
It was
oncologists with us.
for people who is online as well, just to read it.
Okay. So thank you very much for the presentation. Dr. Carmona said, when tracking serial ctDNA to monitor clonal dynamics, at what variant allele frequency trajectory or absolute threshold do you feel the field will be comfortable preemptively switching therapies based on emergent observations or over radiographic progression? So I guess really getting at that SERENA-6 data, and I'm curious, is that an approach that's being used now?
As I said, it's a very controversial approach. FDA had quite, it was almost impressive to watch the ODAC analyze the trial, and they were not super excited, particularly since the trial didn't control the crossover as carefully. But then EMA in Europe recognized the value of essentially detecting potential resistant driver and then putting patients on actually quite tolerable agent to deal with this. To answer your question, this is one of the most difficult questions with any test that's based on continuous readout. Thresholding is something that actually played such a major role in all aspects of our work with ER, with HER2, and it's unfortunately present in ctDNA. Well, I personally feel that at this time with these tests are still not as sensitive as I would want them. A mere presence of a bona fide resistance alteration is very worrisome to me. Whether you're going to make a change at the first step or wait for one more step before you see a clear trend, that's something that we'll have to figure out in clinical practice. But to me, there are so many steps. The tumor has to proliferate. Not all cells proliferate, not all lesions become resistant at the same time. So by definition, you're going to have only a subset of cells shedding. And only that subset is ultimately through exponential growth that will catch up with the patient. So acting on it earlier rather than later would be my recommendation. Whether it's a very first point where the ctDNA just barely across the threshold, that's something that we'll probably all struggle a little bit. But I would say that given the sensitivity of these assays, given this biology that I just told you about shedders versus non-shedders, I would act sooner rather than later.
Thank you for that great presentation. I have a question about the resistance mechanism. So you showed some, this is bringing it back to, I used to do antimicrobial stewardship and, resistance of bacteria. So if you were to, at your bench-based research, if you were to remove the selective pressure from the cells, do they ever, is there a trade-off between fitness and resistance? And if you were to remove that, do you see them proliferate? Could you re-challenge? What do you see? Yeah.
Absolutely. There are the trade-offs. That's particularly true for any oncogene. One of its features is that when you're inhibiting it, you're also disinhibiting various, for example, transcriptional regulators that control upstream input into the pathway. When you now pull the drug, the pathway can be really hyperactive, which could be detrimental to the cell. So controlling optimal level of inhibition, and anticipating these feedback mechanisms is a big part of what we are doing. We also see that not all alterations. We actually have done extensive work with FGFR inhibitors where that's particularly true. You can have a driver, a resistant driver develop that's actually hypomorphic. It actually, the pathway is not as active, so you're resistant to the drug. But now, if you don't have that drug as a continuous selective pressure, actually the tumor will lose that alteration because it wants another mutation that's actually driving the pathway more. So clearly, what's happening while you're on drug versus off drug is not trivial. And trying to understand optimal sequencing strategy will be a big part of what academic centers can do. I think pharma probably will struggle to get really well done sequencing strategy, but I think this is where both accumulation of real world data, sheer amount of patients treated with different strategies where we can then apply appropriate statistics and understand optimal sequences, or doing appropriate sequencing strategies where we control more than one line of therapy. This is what's really necessary. When you guys get in the car and you put in GPS, I want to get home, you're not actually assessing your route, how quickly you go to the first corner. You're interested how quickly you get home.
Yeah.
But how do we do oncology trials? We're essentially assessing drugs by looking at how quickly we get to the first corner. And only through OS readouts, we have some understanding what the actual strategy produces. But OS sometimes comes never because we didn't account for various factors or we didn't power the study appropriately. So we don't really have many times a really clear understanding how entire strategy operates. So this is why I actually like SERENA-6, because your strategy is endocrine therapy and CDK4/6. You're trying to extend the duration of that approach, but you sometimes need to sort of pivot to slightly different agent that allows you to fulfill that strategy.
Thank you.
Thank you so much for that very insightful presentation. I'll definitely remember the one leg, two leg analogy. Just, as we get into increasing biomarker testing and increasing number of targeted therapies, do you feel there is any concern with regards to heterogeneous disease in our approach to treatments?
Absolutely. I think this is where our mind will have increasingly harder and harder time processing this information. We rely on binary things. Present, not present. If present, give drug A. Something else present, give drug B. Problem is, when you have a constellation of alterations happening at the same time, finding the optimal path is a lot harder. And I think there we need some help. And luckily, I see AI as essentially help in processing this vast amount of data that will be coming from a single patient and selecting optimal trajectories, or at least narrowing down a viable strategy. Then we still have to evaluate for that particular patient at a human level. Already it's very difficult. If you look at Garden 360 or any mutation profiling, you'll have ESR1 mutation, BRCA2 mutation, PI3 kinase mutation. What do? Which one do you prioritize? And I just told you the cross-resistance developed, so you can't assume that you can just do all three. Sometimes you have to pick the best one. We are relying a little, and I don't believe I'm saying this, but I'll say it. We rely so much on randomized clinical trials. And we're starting to run out of patients that are actually participating in this trial to help us answer all of these questions. I genuinely believe institutional like yours, institutional like mine, we have to make a commitment that N patient treated at our institution help us do a better job with N+1 patient. Remember, 10 years ago, we used to talk about N of 1 trials. But now what I'm talking about is N plus 1. Like, how do we leverage totality of information about the patient? Almost like a flight, like a pilot. I came on a flight this morning, very, very early. And my pilot had information about flight paths of all planes in the last, I don't know how many hours, and in real time even. And he was optimizing altitude and the course, the heading, based on that information. Do we do this? Two of us can have clinics right next to each other and treat two patients with exactly the same profile. PIK3CA ESR1 BRCA2. And I may utilize one strategy, you may utilize another. How do we even know at the end of the day which one is best? We don't. We can only do that if we test all of these combinations, or if we amass our data and actually create these flight paths off of our own internal data. I strongly encourage you to start thinking about it. I hope you are, because we just don't have enough patience to answer all of these questions. So I'm kind of in a convoluted way, philosophically even answering your question, but hopefully I answered it.
That's a fabulous question and excellent answer. So with that, I would like to thank again our esteemed speaker, Dr. Juric, for joining us today. I love all the analogies and it was a fantastic talk. And thank you again to our sponsors, Novartis, for supporting the session today and for all of you for attending.
Hey,